Hi, my name is Alexis Siegel, and this is my Unit 4 Case Connections analysis and presentation. So the first case I've chosen is case number 1. The question and situation is, a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be best to distinguish between a urea cycle disorder and a disorder in beta oxidation? Please discuss your rationale for your choice. The answers are as follows: blood glucose, B, urinary analysis, C, serum fatty acids, and D, plasma glutamine. So a full blood workup was ordered for this young female, and the data is presented below. So the initial blood ammonia level was elevated at 134, which is the normal range is 17 to 80, so it's clearly extremely high. And it rapidly rose to 600, so that's concerning in itself. The urine orotic level was marked elevated at 437, whereas the normal level is 0 to 3, so that's also extremely high and very concerning. The plasma citrulline level was normal at 10, so that's within the range of 12 to 55. So in this patient where orotic acid levels were elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So narrowing down these answers, we can determine that the answer A, blood glucose, is not correct. So it's incorrect because concentrations of blood glucose are often normal in urea cycle disorders and are low in beta oxidation disorders. So therefore, these levels can't really directly be compared. So blood glucose would not be the correct answer. Secondly, answer B is incorrect because urinary acid testing is complex and is typically analyzed later in a later stage of testing. So that's not something that would have been done immediately. Answer C is also incorrect because serum fatty acids are not used to test for beta oxidation. They are more difficult to test for, and because of this, the process wouldn't have necessarily been completed at that time. So this leaves us with answer D. So based on the answers given above, it's likely that D, plasma glutamine, is the correct answer in order to best differentiate between a beta oxidation defect or a urea cycle disorder. So specifically, glutamine takes part in the detoxification and transport of ammonia. So it's a non-toxic amino acid that's non-essential, meaning that the body can generate it and it doesn't have to be obtained by something that you eat. In the urea cycle disorder, levels of glutamine in plasma will be high, whereas in beta oxidation, the levels would typically be normal. So the second part to this question is the discussion of the enzyme OTC. So based on the lab results given in the question, OTC can be the diagnosis. This is a disease present in males with high ammonia levels, and in females, there is a mutation on the X chromosome. So this could cause these three symptoms that this newborn had. And here in this diagram, you can kind of see where this OTC deficiency kind of comes from. So OTC facilitates the process of carbonyl phosphate into the urea cycle. And as you can see, if there's a deficiency, this would not be able to occur. So the enzyme analysis, the most likely deficient enzyme with OTC, would be OTC. So as shown on this diagram previously, it accumulates in the mitochondria and it may leak into the cytoplasm, which would cause a result in higher levels of orotic acid in the urine. So these raised levels of orotic acid would be able to distinguish OTC from CPS1, so which I will discuss now. So CPS1 is the least likely enzyme to be impaired, and this is because it appears upstream of carbonyl phosphate step in the urea cycle. So as you can see here, CPS1 is further upstream in the cycle, so that would not affect this case. These are my sources. And secondly, case 2. So the case for case 2 is a 4-day-old infant. Patient A is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth, vaginal delivery were normal. Results from newborn screening demonstrated a PHE level of 6.6 milligrams per deciliter, which is within the normal range of 1, or which is without the normal range of 1 to 2, excuse me. So this is extremely high, especially for a newborn. A preemptive diagnosis of phenylketonuria was made, and additional samples were obtained for further analysis. The parents deny a family history of PKU, which is an abbreviation for this condition. As a consequence of this presentation, which amino acid may become essential? The dietary restriction therapy was initiated at 14 days of age, and with good response of plasma phenylalanine levels that dropped within normal range of 1.65 milligrams per deciliter. So then the next question is, what are the potential causes of the presentation of PKU? Another infant, patient B, is also elevated and suspected for PKU. BH4 loading tests are performed on both patients, and results are presented below. So as you can see, the results are here. BH4 loading test tablets of synthetic cofactor are dissolved in 20 milliliters of water in dim light and administered to the patients at least 30 minutes before a meal. So after this, blood was drawn, and 8 hours after BH4 loading, the levels are determined. How would you summarize these results for patient A and as compared to patient B? So as you can see, this question is kind of broken down into 3 parts, so I will address all of these. A consequence of the presentation of which amino acid may become essential is the first question. So as a consequence of the presentation of phenylalanine, may become essential. So this acid can be obtained through the diet by incorporating foods high in protein. And as you can see here, this is the phenylalanine compound. So what are potential causes of the presentation of phenylketonuria? So PKU is a defect in metabolism because of the absence of phenylalanine. The absence of this enzyme can cause damage to the nervous system, specifically the brain, because of the accumulation of phenylalanine, which can obviously be very harmful in high potencies. A potential cause of PKU is autosomal recessive inheritance, which is shown to the right. There's a specific coding deficiency for the gene phenylalanine hydroxylase, which makes the cycle unable to produce tyrosine. So as you can see, in a autosomal recessive inheritance pattern, the affected individual skips a generation. So as you can see, the 2 parents here do not have PKU, whereas the offspring does. So, and if this pedigree was to be larger, you would see in the generation above the parents that it also may be present as well, per se, in the grandparents. BH4 is an essential enzyme for the reaction of phenylalanine to tyrosine by PAH, the PAH enzyme. In individuals with PKU, this enzyme is deficient. So this is kind of the platform of this disease and the pathology of this disease. Secondly, how would you summarize the results of the tests for patient A and patient B? Patient A, levels of phenylalanine rise as BH4 is loaded into the system. So this shows that this person cannot convert the amino acids to tyrosine by metabolism. So this patient could be accurately diagnosed with PKU based on the information given. So on the other hand, patient B, their levels of phenylketonuria decrease as time goes on. So this means that the system is metabolizing the amino acids into tyrosine, which shows that this diagnosis would not be accurate because in that diagnosis, they are unable to do that. Those are my sources for the second one. And that is all. So if you have any questions, please feel free to comment below. Thank you.